Hi, Vanessa.
Hi, Cara.
Today's episode is about when do you move on from your pediatrician, which can mean a lot of different things, right? I mean, there are people who want to move on from their pediatrician when their kid is 6 months old and there's an issue. And then there are people who are reaching out to us saying, is my kid too old for a pediatrician?
Right.
So I think it's kind of important for us to help parse some of the information and tackle really that second question in this episode, which is on the back end. But just because we do get these questions all the time, and we've touched on them on other episodes, specifically, we looked at the question of when pediatricians manage care in our episode about travel. And, when you're away from your doctor, what do you do? But maybe let's just start there and give people who have younger kids a couple of pointers, a couple of reminders, and then let's really get into it. You good with that, Vanessa?
Yep.
All right, here we go. Vanessa, have you ever been philosophically misaligned with a doctor who takes care of you?
That's a really good question. I think that I have felt not philosophically misaligned, but maybe that I wasn't being heard by the doctor in the way I wanted to be heard.
There was a study that was often cited when I was in medical school. I'm sure there is a newer version that has been done since the olden days. But that study looked at the number of seconds a doctor would let someone speak in a room before they interrupted with their questions or comments. So that might have contributed.
How many seconds was it?
It was like 7. I mean, it was something crazy. We'll find the real reference. It might not have been only 7, but I don't think certainly the patients didn't get to a minute. They did not get to a minute.
And it's important to recognize that while there may be a bedside manner issue, it might also be the incredible pressure doctors feel to see a massive roster of patients.
Oh, it was not without good reason. Like if you start telling a story and I'm diagnostically going down a certain road trying to figure out, could it be this? Could it be this? I need to gate your story. I need to get answers to the questions that I have in my head in order to come up with a diagnosis. 90% of a diagnosis comes from history. The problem is if I don't let you speak freely, then I'm shifting the narrative, right? I'm cutting out the things that you might say that would make me think of something totally different. And that makes people feel not heard.
Right.
Rightfully so. So I just am starting with philosophical misalignment, which I think includes this, not being heard. Because it's really important for people to realize that sharing values with the people who take care of you is actually an important piece of a doctor-patient relationship. And as you sort of ride through your many years with care providers, it's a very fair box to want to check. And I think it's appropriate. If it's not a good fit, whether it's for your care or for your kids' care, for whatever tangible or intangible reason, it's time to move on and find someone else. So that's one thing. Vanessa, have you ever been in a doctor-patient relationship where something goes wrong, something goes south, something happens? It could be a dynamic with someone in the office. It could be a misdiagnosis that feels really frustrating. It could be any number of things. But have you ever been in a scenario where it just wasn't all smooth sailing?
I haven't, but I've certainly heard many stories from other people who have, particularly those with kids with really serious conditions or major and unexpected problems in the family.
Right. And the reason you hear more from those folks is that their denominator is bigger. Their number of points of intersection with the healthcare system is higher. And so there's more potential for mistakes to be made. But this is just to say that healthcare providers are human, but things will go awry. Something will happen. Someone will be, I've told this story before. I'll say it again. When I was a medical student, I thought I was doing the right thing. I went I went to have a mole check to make sure I didn't have any skin cancers, because in medical school, every week you diagnose yourself with a new disease. And I went in and gave my history and had an exam, and they left my chart sitting on the desk. And when I looked at my chart, the note said, patient thinks she has melanoma. And it made me feel bad. And I never wanted to see that doctor again. And I never went back. So sometimes things go awry. And it's okay to take that experience and decide you want to pivot your care. It's also probably okay, maybe even a little better, to have a conversation with the person who was involved and try to work it through, especially if you have a longstanding relationship with an office, because we're all human. And if this podcast emphasizes nothing else, it's that communication is king. I had one experience where there was an emotional hurdle in the relationship that the patient found simply too hard to scale. And that's why they needed to leave the physician. It's actually happened to me 2 or 3 different times where I was the receiving doctor who got these patients who came to my office because this same emotional hurdle had presented itself at other doctors' offices. And that was women who had lost pregnancies late in the pregnancy. Babies who were, for all intents and purposes, supposed to be totally healthy babies who were delivered either stillborn or died shortly after birth. And I can think of 3 families in my practice who came via that route, and they simply chose to leave the pediatrician that they were supposed to be with. They didn't even really know that pediatrician, but it was too emotionally difficult for them to continue down a path that was already not the path they thought they were going down. Mm-hmm. And so they just wanted to clear their decks and start all over. And when they did end up having kids, switched everything, switched their OB care, switched their pediatric care, switched everything they were doing through the entire pregnancy. It felt very reasonable to me. I think that, again, it's a very human thing. It had nothing to do with the original doctors at all. So that's sort of, it's a different category of reason why someone would leave. And then there's finally subspecialty care. So, Vanessa, I know your answer to this, but I'll ask it anyways. Have you ever taken any of your many children to a subspecialist, which is the opposite of a generalist, right? It's not a general pediatrician. It's a pediatrician who has specialty training in a specific organ system or in a specific arena.
I certainly have, for a wide variety of reasons.
And the reason I ask it that way is that I want to ask the follow-up question, which is, have you ever been tempted just to move your care to that person and be like, this is the primary thing that's going on for my kid, and I don't need to see the pediatrician. I know I need to come back to this office several times. I'm just going to kind of ask this person all my general questions. And if they answer them, great. Like, we're good. That's a doctor, right?
Yeah. I mean, I think it depended on what the care was. So I always wanted to get a recommendation from my kid's primary pediatrician because they had so much more knowledge than I did. And also, if they had a relationship with that specialist, then I knew that they could communicate with each other more easily, which would make my life easier. I mean, there's some folks like an allergist who I then establish an ongoing independent relationship with, because there's all sorts of stuff an allergist needs to see your kid for, which reminds me I need to make an allergist appointment for one of my kids. And then there's stuff like an orthopedic surgeon. And so I think that in that case, it was really not one-off, but, thank God there was only a few times I needed to see someone, and folks like that. And listen, sometimes you have better chemistry with the specialist than you do with the general pediatrician. But I also was really conscious of finding specialists who took our insurance. And by the time you get done with someone your pediatrician recommends and someone who takes your insurance, the pool gets pretty small and you feel pretty lucky when you find someone you really like and your kid likes. One of my kids had to have a hernia repair at 15 months old. And she loved the doctor so much and she loved her experience in the children's hospital so much that she wanted to take home her little gown, the little baby gown that they gave her. And they also had her riding in a car. And so it was less that I was tempted to switch to them and more, I think I was so grateful that in a stressful moment, I found someone I trusted and she had someone that she felt super comfortable there too. One of the funny things was, I think part of the reason I like this specialist so much, it must have been a GI, a pediatric GI. Okay.
Or a surgeon, one of the two.
So one of my kids, because two of my kids had hernia repairs and one of them had come out of surgery and I had a baby at home and I can't remember exactly which kid it was and which baby it was, but needless to say, I was fairly frazzled. And he was like, okay, so the bandages come off on Thursday. And I'm like, okay, so today is, and I couldn't even remember what day it was. I had no idea what day it was. And he looked at me and he said, do you know what we call that? And I said, what? Not knowing what day it is? And he said, yeah. He said, just some of these details, he said, we call it a maternal steal. A steal in medicine is where the blood gets sucked to some other part of the body to deal with the situation. And he said, your blood is going to all these other places away from your brain because you have so much on your plate that your brain isn't getting the blood it needs because it's being called on so many places. And it was such an empathic, funny, kind way of looking at a frazzled mom and kind of being really human about it all. And so I would say that was a very wonderful experience I had with a specialist.
I've never heard maternal steel, but I think that's a really sweet way of describing it. I like that.
It was good. I really loved it. It wasn't at all patronizing or demeaning. No. It was very much hey, I see how much you're handling and your kid has just come out of surgery and you're stressed and relieved. I'm here with you. I totally get what's going on. It was very lovely.
That's really lovely. Now I call it menopause, but then I would have called it maternal steel, my inability to remember what day it is. So what you've described is spot on, which is the general experience when people finally make it to a subspecialist is that their shoulders drop 6 inches. I'm here, I'm at the subspecialist, and someone's going to do something about the problem, right? You got to surgery, the problem got fixed. You get to, an allergist, you get the right allergy medicines and you know what things to avoid, right? It just feels, and that can really bond people. But then what sometimes happens is that because the patient and the family and the physician get really bonded, sometimes the patient or the patient's family really do want to just be in the care of that individual subspecialist. And it puts subspecialists in this awkward position because they love that deep connection, but they're not primary care doctors. And sometimes people don't have the resources, the time resources, the financial resources, as you described, to go to multiple doctors. And sometimes they are leaning on their subspecialists. I mean, the classic example is an OBGYN.
Right.
And we're about to talk about when your kid is too old to be with the pediatrician. And most women at least some point in their life, if not for most of their adult life, consider their OBGYNs, their primary care doctor, their internist, right? Your face,
I mean,
you're
I had certainly a decade where the only doctor I saw was a OBGYN. And in the previous decade, probably most of that decade was either a midwife or an OBGYN with almost no primary care. I figured I'm getting my birth control, I'm getting my breast exams, I'm getting sort of the the thought and care of a medical provider sort of checking in with me. And I didn't have time to go, or I didn't make time to go see a doctor for myself, even though I probably spent on average once every 2 weeks, I was taking a child to a doctor for something or another.
And this is not to say that there aren't OBGYNs out there who do fabulous primary care. There are, but it's not the lens through which they were taught to provide care, right? Primary care doctors provide care in a certain way. They see things from 30,000 feet. They offer anticipatory guidance in a very specific way. They're thinking about certain diagnoses that an OBGYN may or may not be thinking about. They're trained in a slightly different way to think about slightly different diagnoses. And the truth is that in a perfect system, you've got more cooks in the kitchen. You've got people looking at the problem from multiple perspectives and talking and communicating. But we live in not a perfect situation, Vanessa, in this country with medical care. And so the question becomes, where's the trade-off? And specifically, at what point does a kid need to graduate from general pediatric care, and who should be in charge of that care as they get older?
So, Cara, traditionally, what are the ages of kids a pediatrician would see, and how, if at all, have those ages changed? I mean, obviously, when we were pregnant, you had to find a pediatrician before, God willing, you actually had a living child. And that pediatrician had to see the baby within a certain period of time after it was born, in addition to the pediatrician who's in the hospital doing rounds and, checking out the baby. So we know the front end of it. But where does it end?
That's what people ask us about puberty all the time.
Asking for a mother with a 22-and-a-half-year-old.
Well, I mean, I want to sort of go from the front end first, because some people are cared for by pediatricians from day one, and some people are cared for by family practice doctors from day one.
Right.
And family practice doctors have been trained in pediatrics, internal medicine, and OBGYN. They get a little less training in each of those than the people who practice each of those. So a pediatrician has 3 years of pediatric training, right? An internal medicine doctor has 3 years of internal medicine, et cetera, et cetera. A family practice doctor cobbles together some pediatrics, some internal medicine, some OBGYN, but they have a lot of experience in all of them. And so the answer for that group, if you are cared for by a family practice doctor, winner, winner, chicken dinner, you do not ever have to leave that primary care doctor. The catch is twofold. The first is it's kind of hard to find a family practice doctor in certain places. This is an area of medicine that is commonly practiced, but not as common as internal medicine or pediatrics. And then the other is, among family practice doctors, many will specialize. Like, I know a ton of really wonderful family practice doctors in LA who do not do pediatrics. They do internal medicine. That's what they love. They do a little bit of GYN. But what they really love is internal medicine. And this is not to say they weren't trained in pediatrics, but, so there you have it. If you've got a family practice doctor who loves to practice all of these areas, then great, you never need to leave. If a patient is seeing a pediatrician, it used to be that off to college was a natural breaking point for the relationship. The pre-college or graduating high school and leaving the nest visit would be a goodbye. Here's some last pieces of advice out the door. You can always call me if you're in a pinch, but we're going to look to transition your care now. And that would sort of be 17, 18, 19 years old. And there were a lot of really good reasons for that. I mean, one is that by the time a kid is through college, they are really physiologically adult. Before they go to college, they're at different stages with different organs, but mostly they're there. So I'm going to give you an example, Vanessa. Do you know what an EKG is?
Was that the heart one?
Yeah, it's a heart monitor that is put on there. There are these little stickers that are put on your body. You might have a 12 lead, which means there are 12 little wires going into the machine, 12 stickers on your body. You might have a smaller number. But these measure, EKGs measure the heart rhythm. And the EKG of a newborn looks different than the EKG of a kindergartner, looks different than an EKG of a 16-year-old, can look different than the EKG of someone who is an adult. And the reason why is because you are looking at essentially the pump function of the heart through electrical signaling. And based upon where the stickers are placed on the body and the size of the heart and the way the heart actually tells itself to pump, the waves that appear on that EKG flip at different ages. So when you ask an adult cardiologist to look at a baby's EKG, many of them will say, I do not read pediatric EKGs because the shape of the waveforms is fundamentally different. And what can be completely normal in a 6-month-old EKG can look like there's a major cardiac event in an adult. Okay. By the time a kid goes to college, their EKG is largely an adult EKG. Not always, but mostly. It's a great example of how pediatricians, especially pediatric cardiologists in this example, are trained to see hearts one way. But once the body evolves and changes, the baseline of what is expected or normal or healthy has shifted. And it does not make a lot of sense to continue care with a person whose lens is looking for one type of EKG when really you need them to be looking for a different kind. So the olden days, 18, 19, people would move on from pediatricians. Today, it feels pretty different to me. It actually felt different to me even when I started practice 25 years ago. We were already seeing kids who would stay with the pediatric practice all the way through college. And they would do that because when they got strep or mono or flu or any number of infectious diseases at college, if they went to the college health service, they could get tested and treated, but they didn't always feel like they could get good follow-up care. And so they started reconnecting with the pediatrician for the follow-up care for those infectious illnesses. Ditto STIs and STDs, ditto social and emotional issues, right? So the college health systems are not by and large designed to have continuity of care with one person. They're really more urgent care style. And people wanted that continuity of care, right? If the rate of asthma is going up and up and up, and you want to prevent asthma, one of the most important things you can do in terms of preventing asthma is to have a direct line of communication with a doctor who is helping you figure out how to avoid it. And if you start wheezing, what to do. The college health system is not designed to have a lot of that back and forth.
Right. And I think the trust that kids hopefully have established with their pediatricians allows for a kind of shorthand or cutting to the quick of complex issues, or even things that are going on for a kid that might not even be physical, but it's someone they see or have come to see as a trusted adult at a moment when, they are far from home or not. They may feel more distant from their parents or not. They may have lost some trusted adults from high school that, they're not in touch with in the same way, but this is a continuity of care in that sense. So I think I definitely understand it. I mean, honestly, Cara, I left my pediatrician, went to an OBGYN for care, and I basically never had a primary care physician.
Super common.
Years, unless I got sick. I had to find someone for a while. We were in a family medicine practice because it was so much easier for me to get my kids their strep test and get my strep test, or all of us got the flu shot at the same time or whatever it is. It was just simpler. But, one thing I want to do differently with my own kids is making sure that if they do transition, particularly my daughter, to, an OBGYN, that they still have a primary care physician.
Which is going to be really hard. I'm here to tell you, Vanessa, that there aren't enough primary care physicians and that the sickest members of society need them. And where they're concentrated is also very different. But it is getting increasingly hard to find a practice that will accept new patients, whether you're in an urban, suburban, or rural setting. I mean, here in LA, I have so many friends who are internists, and not only are they not accepting new patients, but they don't have anyone to refer us to. In fact, I think probably the biggest growth opportunity in primary care is this group that you've identified, which you've been a part of and which I've been a part of, which is the 20 to 40-year-old, 20 to 45-year-old well care group, right? And it's so funny. I was traveling this weekend and I was sitting next to a guy on a plane and we started talking about what will the future of healthcare be, and specifically for that group. And the answer is, it's very clear already. It's going to look really different. It's going to look like screening blood tests to pick up all sorts of things from cancer to an infectious disease you never knew you had, but puts you at risk for certain things, like H. pylori for ulcers or HPV for cervical cancer. It's going to look like scans, nothing that needs to be done with direct communication with the doctor. And yet, we are at a real crossroads where what we don't know is, will people still opt for people? Will people still want a doctor, a healthcare provider to help them interpret all the findings that are going to come back? Or will they be willing to do it through AI? And everyone I know believes that what you and I both experienced, which was go from the pediatrician to the GYN, and that was where all of our care was for a couple of decades. We're all here to say, I'm not really willing to turn that care over to a computer until I get pregnant. I would like a person. And so we have to figure out who that person is, because there aren't enough internists, there aren't enough family doctors, and there aren't enough OBGYNs. They're being pulled in every direction too. So even if they could do it, their bandwidth is limited by the other kinds of care they're trying to practice, which leaves us in this weird position because we're asking the question, when is my kid too old to go to the pediatrician? But I'm sitting here telling you, there is no alternative to your kid's pediatrician that is readily available and accessible. And that's one of the reasons why pediatric care has extended into the 20s. Because pediatricians are very happy to continue that care, especially for anticipatory guidance. Making sure kids are aware of consequences of sexual choices and drug choices and choices about, getting onto motorcycles and getting all the things, right? But there's truly nowhere for them to get guaranteed hands-on, hand-holding care like they got at the pediatrician for the next decade or two. Just complicated.
Yeah. And by the way, there aren't going to be enough pediatricians either.
That's like cue the saddest music ever in the background, because that's true. So the model for connecting with and trusting a healthcare provider is going to look very different.
And Cara, what if you've transitioned to an adolescent medicine specialist for your kid? And for those who listen to the podcast know, there's only about 700 and something adolescent medicine specialists. We did an episode with Sarah Levine, who is one. We did an episode with Hina Talib, and we'll do another one with her in the fall. And I like to call them unicorns. I think they're amazing. Can you explain what makes them so special and kind of how this issue relates to that group?
Yeah, most of them are pediatricians. Some of them are trained as internists, but they went back after their general training and they did a subspecialty in the field of adolescence. So they actually got hands-on hospital-based and clinical training that looked only at tweens and teens, and mostly at teens. And so they have more depth of knowledge in GYN care than a traditional pediatrician or internist. They have a lot of training on STIs and STDs. They know a lot about substances and addiction. They know a lot about decision making and brain maturation. And to be in the care of an adolescent pediatrician is really magical. It is unicorn-like because these are people who they're not juggling talking to a 2-year-old with talking to a 15-year-old. All day, every day, they are in the mud with the teenagers and they love it. And their lens is very, very focused on what kids that age are doing, what choices they're making, what language they're using, what hurdles they're facing. This is not to say that a general pediatrician doesn't love it and doesn't know all those things too, but it's just, there's a lot to be said for someone who loves that age group so much that they stick deep with them. Most of the adolescent medicine doctors that I know continue care well past adolescence, right? They go well into the early to mid 20s. But again, for all the reasons, they don't go much further.
So the next thing we're going to cover is, what do you transition care for, and how do you figure out who the right folks are given some of the challenges we've talked about? Concerns about trust, insurance, a shortage in providers, all of those things. There is still a point where young people have to start seeing adult providers. So we will figure out all of those answers. And unfortunately, some of those answers may be, it depends. So, Cara, the first time my oldest was sent to see an adult physician was when he needed to have his nose cauterized. He was having just constant bloody noses. And the pediatric otolaryngologist, you're welcome, Nina Shapiro, the pediatric ENT that he had seen really recommended he go see an adult ENT. So I sent him on his own. He made the appointment on his own. He went to the appointment on his own. He was probably like 19 or 20.
Okay. Cusp adult physically. Yes. But we were building all the skills of, getting the name and making the appointment and handling the insurance and getting yourself to the appointment, all those things. And then he went. And he was so unhappy because the guy treated him not like a kid, like an adult. This doctor was curt and he didn't kind of warm him up. And, cauterization doesn't feel so awesome. And he was kind of like, all right, see you later. There's not the sort of loving wraparound that he was used to from the pediatrician. And I'm not going to lie, he was like in a little bit of shock. And when he needed to get the other side cauterized, he went back to his pediatric ENT. He was like, I am not ready for this moment. I'm not emotionally prepared for this change. For those who don't know what cauterization is, it's a burning procedure where literally you take a super hot electrically heated tool and you burn tissue to make it stop bleeding.
I mean, some of us would have had it right from a colposcopy. If you had an abnormal pap smear and then they take a little bit of tissue and then to stop the bleeding on your cervix, they cauterize you.
There are lots of ways cauterization is used, but it is both. It sounds like you're at the dentist. It smells like something's on fire.
Yeah.
And it's uncomfortable. So it's like the trifecta.
I really threw him in at the deep end.
That was good parenting, Vanessa. You let him stand on his own 2 feet.
Lesson learned. Yeah. So that was an example of a specialist.
Yes.
He is still seeing his pediatrician.
He's still afraid of adult doctors to this day.
He loves his pediatrician so much.
Well,
and
we're nice people,
this was actually someone we transferred to when my older kids were, I guess, in high school. And it is a pain in the butt. It is a huge pain in the butt to transfer providers. But it was so worth it because my boys wanted to see a male doctor. My daughter wanted to see a female doctor. That's part of what inspired it. And I feel like my boys don't want to leave. Like I'm going to have the conversation with the pediatrician. Like, are you going to have to push them out of the nest?
So let's talk about that, because I think there are pediatricians who are starting to say, I'm getting myself really educated on adult physiology so that you don't need to leave too soon. I mean, there's going to be a point. There's always a point. But like, I think
when he becomes a father.
Yeah, that line may be somewhere close to that. The depth of the relationship isn't just enjoyed on one side, it's enjoyed by both. These deep, connected, historical through time and lived experience relationships mean a lot to both people involved. And that's why when we ask people, like, do you remember your pediatrician? Most people will say, oh, some people will be like, oh, my pediatrician was terrible. I mean, you always get that.
One of my kids' college roommates is the grandson of my pediatrician.
I mean,
that is how much we loved him. He was like the kindest.
Vanessa,
he's still alive. He was the most amazing doctor.
My pediatrician when I was growing up and my husband's pediatrician was Dr. Care, but it was spelled Kehr, Dr. Care. And my mother-in-law loved him so much that she saved the notes he used to write at the end of each visit. And one of the notes that she gave us to hold on to was on an old school prescription pad. And it had Paul's name at the top. And it just said, 4 months old, may eat bacon. Just a timestamp. Hi, 1963.
God, so hilarious.
Isn't that amazing? But like,
may have lard in his rice cereal.
I mean, I think he was going to let him gum on bacon, but like, so these stories, these connections, they're deep and they're real. And no one is trying to cut them off prematurely. And so I do see, frankly, with my own kids who still go to the pediatric practice where I practiced. And one of my old partners is like, a sister to me. They still turn to her when they have questions that they would like a completely unemotional response to, because I play the role of mom for them, not the role of doctor. So they will call her when they sort of need to fact check something in a way where all emotion needs to be removed. And, they're pushing up against the limit of being able to do that. But I think I keep using the phrase anticipatory guidance, some of these conversations that have to do with what if I'm in this situation, or what if I'm faced with this kind of decision? Those are questions that, frankly, pediatricians and family practitioners are better at managing than internists. The experience that you had, or that, was had at an adult ENT, is the experience of adult medicine tends to be less handholdy in certain ways. Now, my husband practices cardiology. Cardiology spans the entire lifespan, but has a very large concentration of patients at the back end of life. And those are incredibly deep and meaningful relationships that feel a lot like pediatrician relationships to me. Like, those are people who are so connected to my husband, and he is so connected to them. So I don't want to give the impression that these deep and connected relationships cannot happen in medicine. They can happen at all ages and stages. But we have a system that's pushing against that. We are moving in a direction that suggests that's really not that sustainable. And by the way, your kid's physiology is going to shift to a point where a pediatrician is not the best person to be listening to their heart, listening to their lungs, and making sure that everything is A-okay. So, I mean,
can
let's
we talk about
it.
Yeah, I mean, can we talk about one of the most common questions we get from parents of girls or people with vaginas and uteruses, and it's about when should they go see an OBGYN for the first time.
Right.
And some of you may remember the episode we did with Megan Leahy and her fabulous daughter, Sophia, who was a girl and identifies as a girl and was going through what appeared to be female puberty, and then had incredible abdominal pain. And after some emergency room visit and some sonogramming and deeper look into her body, they realized she had a condition called MRKH, and she did not have a uterus. And so, she was 13 because they had an emergency situation and they had to deal with it. So Megan's point when we interviewed them was like, I never expected that would be the point that my kids started seeing a specialist. There are other people, the question comes up because of difficult periods, extreme cramping or really heavy bleeding. Other people, it comes up because of they think their kid or they know their kid is sexually active, right? So 2 questions. One is, at what points is a pediatrician able to provide some of that guidance and medical care? And is there a point at which either an age or stage or need where you really should go to an OBGYN?
Yeah. I mean, this is where having direct conversation with your healthcare providers is everything. So ask your doctor. If you're living in rural Idaho and there is one family medicine doctor or one pediatrician and no family medicine doctor, and you're stressed out because you think, oh, my kid's hitting a certain age and I think they need advice about, birth control or STI prevention from an OBGYN, that care provider may say, I provide all the care for everyone in a 500-mile radius. And the truth is, I can do this. This is very well within my practice. And I've done this for a lot of people. Whereas if you are in New York City or in Los Angeles, where there are doctors' offices on every corner, you may find that people narrow the scope of their care because there is someone down the street who can provide that more specific care. And it might sound better, but it might not be because it's more inconvenient. It requires multiple visits. It requires multiple payments. It requires the doctors communicating, like all the things you started off with, right? So the answer is ask your care provider, hey, I'm wondering, are you the person who's going to go over this and this and this with my kid? Let's do sexually transmitted infections. Great example, right? Hey, pediatrician, I'm just calling before my kids visit because I'm curious, like, who does the conversations? I've had the conversations about STIs, but which healthcare provider does this conversation? When does my kid need to see a gynecologist? Who will communicate that with my kid? How do I know when it's time to add that level of care? I know you have private conversations with my kid that you cannot share with me unless they're going to hurt themselves or someone else, right? That's the law. But when do I know that I need to help facilitate an appointment with someone else? Like, help fill me in. And the beauty of having that pre-conversation is, number one, it gives you answers that are specific to the care that's happening in your vicinity. Number two, it tees up that healthcare provider. I need to go there, even if I wasn't thinking I needed to. I'm putting this at the front of my mind, not in the back of my mind. And number three, it's a practice for how you're going to communicate that with the kid in your life. Because that's the other thing is, if you're having these conversations with the doctor, you should also be having these conversations with your kid. Hey, I'm curious, when you go get your annual exam, can you make sure that you get some more information about STIs and when you need gynecologic care from your doctor? I'm going to ask all the same questions, but I think it's important for you to know, right?
Yeah. And I think, I do it a little less subtly, but I will say, hey, I know you guys are going to have some time together without me in the room. Can you please make sure to cover these 3 subjects? Which promptly elicits an eye roll and an, oh, mom, from my kid, and a chuckle from the doctor. I actually had a hilarious experience where the pediatrician was having a conversation with my kid about no sexting and, all of that. But he was saying it in such a nice, polite way. And I finally looked at my kid and I was like, do you know what he's talking about? And he's like, not really. And I was like, no dick pics. And he was like, oh. But it's, there's
Which teaches the pediatrician, by the way.
Which teaches the pediatrician, and also conversations about, for example, I have a kid looking at college and she's concerned about reproductive health in different states. And so we had a conversation with the pediatrician about, should that play a role in college, and what does transition to care look like with the college health services? And her point was actually really interesting, that in her experience, college health services are really excellent at providing gynecologic care, inserting IUDs, sort of managing that side of things, which, I was in college so long ago and I didn't rely on college health services for that. So that was super interesting. I really learned about that. The other thing is, if you do have a kid who's thinking about college or going away to college or at college, find out what the mental health services are on your kid's campus. More and more campuses are providing really robust mental health services, often for free, or a certain set of sessions are free. And they're taking it really seriously, and take advantage of that. It's incredible to have access to that.
It's such a great point. I think this takes us to the right spot to land, which is, there are all these options out there, right? There are ways for care to have continuity. There are points at which care needs to move on. But the place that we have the most room for improvement as a society is the integration of all the information about one person's health so that everyone can take better care of their patients. So what do I mean by that? Vanessa, you've described along this podcast taking your kids to a number of subspecialists, having them go to college, having them get care at college, having them come home, having them get care at home. And in the name of privacy and in the name of not losing access to your own data, we have landed with a system where their medical records are by and large scattered all over the place. They don't know where to find them. They don't know how to consolidate them. And the people who are taking care of them, particularly the new people who don't know their history, or their original pediatrician who may have missed the last 9 months because they were away at college, they don't know what has transpired in this time. And they're relying upon a history where there's really a robust medical record. And so my hope is that as we evolve our health technology, we will find a way to prioritize centralizing patients' information, not so that patients can look up their own labs and get completely freaked out and go onto an AI bot or onto Google and start searching, what does this random lab test mean, which is where we are now, but rather so that patients can get the best care possible as they move from provider to provider. And so for anyone out there who is looking at building novel technology or novel systems within healthcare, as a pediatrician, I can say, I think I speak for all my fellow pediatricians, that's where the biggest need is right now. Like, we know how to do what we know how to do. What we don't know how to do is communicate through a kid or through a family to the next person who are handing the baton off to. We don't have a baton. And that, if we have that, that will change this entire conversation that you and I are having.
So for those of you for whom this feels relevant, including the two of us, it's a good time. You know, a lot of kids' annual physicals are coming up. It's almost May. That reminds me, I need to schedule my kids' annual physicals. Make your list of questions, as I hope you do before you go into these appointments, and add this to your list and start to think about it. And it's funny how in this age of technology, the personal relationships amongst healthcare providers still is very intimate, right? Who they refer to and who they know. My kids have been taken care of by a variety of dentists and oral surgeons and pediatricians and all these folks who all go to concerts together. They're like huge Bruce Springsteen fans. And so they're like, I walk into different offices and it turns out they all know each other. And you kind of have to say, like, is it time? How do I know? How do I begin the process? Who do you trust? Knowing my kid as well as you do, what would you recommend? Knowing me as well as you do, what would you recommend? You know, modeling for kids what it looks like to have a thoughtful, ongoing relationship with their own health, and in really pursuing healthcare providers who they trust to take good care of them. Because that is a lesson that hopefully we can teach our kids as they grow and begin to take care of themselves.
Thanks, Vanessa. We better go and make a bunch of appointments.
Thanks, Cara. Thank you so much for listening. You can email us with questions, feedback, or episode requests at podcast@lessawkward.com.
If you want to learn more about what we do to make this whole stage of life less awkward for everyone involved, our parent membership, our school health ed curriculum, our keynote talks, and more are all at lessawkward.com.
And if you want products that make puberty so much more comfortable, visit myumla.com.